to Plastic Surgery Consults with the McRae Twins and Matthew McRae and my twin brother, Mark. Hi there. Yeah, we're excited to kind of get going on this project. Last episode was just a little bit about ourselves, and today we're doing a bit of a deeper dive into really common procedure we do in our practice, which is that of breast reductions. And the name of our podcast is Plastic Surgery Consults, as we mentioned. And we're spending a bit more time today on things that come up in our consultation process with patients. Now, today is a topic of scars and scar placement, as well as the process of healing of scars. And this really impacts all patients, but particularly younger patients of younger age demographic that come to see us.
Matt, maybe you can discuss a little bit about what you're seeing in terms of the patient demographics that we're seeing. Some pretty notable changes in the last decade or so of our practice.
Yeah, that's right, Mark. So about when we started as plastic surgeons, so that was technically in 2009, and started as kind of independent staff surgeons in 2014. The typical breast reduction patient was a woman who had had her children, so kind of in the 50 to 60 age bracket. And some of their friends had breast reduction, and they were then interested in the benefits of a breast reduction, mainly to their upper back, shoulder, and the functional improvement that they could expect with the surgery. Now, in recent years, at least in the past couple of years, at least the past 5 or 6, I'd say, it's been a remarkable change in terms of the uptick and increase in the number of women who are significantly younger who are coming for breast reduction. And do you have a suspicion on why that might be, Mark? Why kind of women in their 18 to 20s are now coming to see us versus maybe 10 years ago?
I think for better or for worse, there's a lot more access to information about different things. I think people's relationship with their bodies can be also influenced by things like social media, internet, and that may be a little more complex than we can understand. But we do know that this is a surgery that has a very high satisfaction rate based on the ability to help functionally and aesthetically. To really parse out, though, why we're seeing such a rise in younger patients, it's tough to say. I mean, I know that you've made this comment before that a very common post-surgery comment from patients is, "Oh gosh, I should have done this way sooner." So I don't know if that message is getting out to people when they're younger now, with information being more available. But certainly it does present a certain set of challenges in the younger patient that, again, I think you and I both traditionally have always told patients that if they can wait for surgery, then waiting for surgery is a great idea because you avoid any kind of issues that you can have with surgery. So what are your thoughts on that?
Yeah, so I think you're totally bang on in terms of patients saying, "Gosh, this is something I wish I did sooner," and that's very common. I mean, I've done breast reduction on patients in their 70s, and obviously they're like, "Gosh, why did I not do this many, many decades ago?" And I think within families, there's a lot of communication as well. So often you'll do a breast reduction on a mother, and she knows her kids are dealing with those same issues. So it's very common, I think, in our practice to be operating on multiple family members. The word gets out, and it gets out organically. I think plastic surgery in and of itself is less taboo than it was even 15, 20 years ago. I think people understand the functional improvement, the aesthetic improvement as well. But the idea of doing a surgery for aesthetic and functional purposes, I think, has become a bit more accepted by our society as well. So I think there's many different factors that have led to this increase in younger people coming to us for breast reduction surgery in particular. And yeah, I think you're right. If there's a significant benefit to someone's life, they do tend to want to share that with their peer group, with their friends, with their family. And I think that's led to that demographic shift. So I think what we wanted to address were 3 questions today that younger women have, younger being defined as women. We can't really operate on women below the age of 18 without specific consent. So maybe we'll just stick to the 18 to women in their 20s, the big hot button topics that they really want to talk about. And sometimes we have sometimes these consults can take up to half an hour, but there's so much to cover and we can't really get into the very specific questions as much. So I think this is a good opportunity for us to spend a little bit more time on maybe the 3 hottest topic questions that really come up almost every time with a woman in that age group. So I think number 1, Mark, you think we're mentioning is the idea of scars and scar placement and the breast and breast reduction. So can you maybe get into?
Yeah, it's really interesting though that I can say that it is generally speaking something that patients accept, is the idea that there will be permanent scars on the breast. But I'll also say that generally speaking, we do receive very few complaints or concerns long-term about scars. So I think that's very interesting, because you're going from no scars on the breast to visible scars that do fade quite nicely, again, by the 1 to 2 year mark, generally speaking, in terms of scar maturation. But I think they are important, and they are permanent. So why don't we discuss a little bit about, maybe you could discuss the general scar patterns for breast reductions, because there really are, I would say, maybe 3, but probably the 2 are the most common. Do you want to just mention what those are?
The most common ones that you'll see kind of with online searches, one would be the lollipop reduction. So that's where the scar on the final product of the breast is around the areola. So there's the nipple on the center of the areola, and then around the areola itself. So the scar itself will be around the areola, because generally when that areola is moved, it's usually moved up the breast with a reduction. When it's moved, that areola is very often changed as well in the surgery. It's often changed by reducing the areola size. Many people have enlarged areolas relative to their breast shape. So there's a scar around the areola. Something that really is advantageous about that scar is that the areola itself and the surrounding skin have a different pigmentation. And it tends to be where there are these offsets and changes in pigmentation. Those tend to be great spots for scars, because your eye is not drawn to them as much. It's this natural break point. And when a scar goes in a natural break point, then it's less obvious and more well tolerated. Next, the scar that in that lollipop pattern is from the most inferior part, the 6 o'clock position on that areola, down to what's called the inframammary fold. And maybe we'll be able to get a picture up to show that. And Mark, maybe you could talk a little bit about that incision.
Yeah, so that incision is something used. And so sometimes people will actually call a breast reduction a certain type of reduction. They may call it a vertical reduction. They may call it a lollipop reduction. That's kind of just naming it based on the incision pattern in the skin. So I think that isn't always exactly, like, the incision pattern doesn't predict the actual surgical technique. But anyway, predominantly with most surgeries, you'll have that incision you mentioned, then the incision that goes down between the areola to the fold of the breast. And then from there, the additional technique or type of incisions would be something called the traditional, more wise pattern. Very useful incisional pattern, and that will extend along the fold of the breast, the inframammary fold. And so that allows that skin to be removed in that vertical direction, as opposed to this incision downward, which allows the skin to be removed kind of horizontally. So generally speaking, I think in our practice now, by far the most common use is the lollipop. So it's less incisions, less scarring. I think most patients are interested in that. And I think that goes down to this a little bit more in terms of the technique we use personally. And I don't think we need to go in a deep dive on that today. We will certainly do that in the future. But those are the main 2. So what might be referred to as the anchor incision. So that's the one that's around the areola, down the breast from the 6 o'clock position to the fold, and then an incision along the fold. There's some modifications to that wise pattern. So that incision can bend upwards onto the breast wall. It can improve the shape of the breast more. Either way, both incision patterns are good tools. We do use them both in different settings. I will sometimes use a wise pattern in the more breast reconstruction, symmetrizing surgeries, trying to get symmetry for certain conditions. But in general, I think the technique with the lollipop incision is much, much more common in our practice.
Yeah, I think also another factor related to that is just the amount of skin that has to be removed. So depending on the skin quality, so if the patient has like a very thick dermis, very high quality skin that will rebound significantly, then you can get away with taking off less skin. Now, if they have a lot of excess skin, if they have a lot of ptosis where the breast really drops very low, well, in that situation, you may really want to take some more skin out than is possible with the lollipop to be able to give it a good shape that's reliable on the table. And that will require us at least a small transverse incision at the inframammary fold at the base of the breast. So yeah, then there are tricks that we use. Things like liposuction really help in reducing the overall scar burden on the breast, the amount of scar that's used. Okay, so maybe you could just tell me, Mark, in terms of why those scars are placed on the inferior half of the breast, and why those are better tolerated.
Yeah, I mean, I guess I could maybe let you get into that a bit more. I mean, I think obviously in terms of now we're getting into a little bit more in terms of techniques, in terms of strategies for removal of breast. In my training initially, going back to the 2000s, we were using a lot more. We were talking in terms of blood supply to the nipple areola. So again, you're moving the nipple areola upwards, generally speaking. And in generally, we are also moving the whole breast upward as well. That involves removal of tissue from the breast in certain areas, and strategically, removal of the tissue in the inferior part of the breast makes the most sense, because it allows you to then reconstitute and rebuild and reshape a new breast further up the chest wall. That goes back to blood supply, and we can talk about that. But back when initially in training, the blood supply for that nipple areola used to come from the bottom of the breast. But that has been a fundamental change, I think, which does have pros and cons. But I think in terms of lifting the breast, which is what we do in all of our breast reductions, it allows us to do that much more effectively.
I was actually just referring to the scar itself. So the scars on the inferior half of the breast are generally well covered with clothing, with a bra, with a bikini. So as long as those scars are not on the superior aspect of the breast, which are obvious in like a low cut shirt, in most kind of clothing or bathing suits, they're well hidden and not obvious, right? So obviously I completely agree with you, Mark, in terms of the actual removal of breast tissue as well, but just kind of more on the scar topic.
Oh yeah, that makes a lot of sense. Yeah, sorry about that. And I think you're right. Like a common mistake for surgeons that are early in their careers is actually bringing the areola too high. All right, so it's a problem if the areola kind of sneaks out of dresses or bathing suits. So that is something that the actual positioning of the scars is very important. And the positioning of the areola is very important.
Yeah, and then could you also comment, earlier you mentioned about maturation of scars. So how does that work exactly? And how do you kind of advise patients when you see them about that process?
So at the time of surgery, like we really are injuring the body when we do a surgery to remove tissue. And that starts a process of healing almost basically immediately. Like the blood goes to the area. There's different things that come in. There's something called macrophages. There's something that kind of come in and clean up the area. There's something called and start different cycles of hormones being released, etc. And then there's something called fibroblasts that come into the area very quickly within a couple of days. And those fibroblasts lay down collagen, and they initially do it very robustly, and depending on your age and health and healing factors, that might depend on how robust and how strong those fibroblasts are. And they're going to lay down collagen in a very haphazard, disorderly way, kind of like just a bunch of collagen getting thrown down in a random pattern. Over the course, though, of months to a year or even two, that collagen is going to get reorganized to much more laminar, we call it, but it's basically more like a smooth, linear scar pattern. And so that process really starts immediately at the time of surgery. That really robust laying down of collagen really within that first 4 to 6 weeks is when you're going to really get the real buildup of scar tissue. And then really over the course of that year or even two is when you're going to get much more smoothing and maturation of those scars.
So for a patient then, when they're looking at their scar, then how does that change? When they're looking at the scar, does it start a certain way? How does it change over that year that you're talking about if they're looking at their scar?
Yeah, so initially the scar is going to be obviously quite visible. It's going to become more red and more pronounced over that first initial time period. When the dressings come off initially, the incision line is actually going to look pretty lumpy, bumpy, and that's actually completely normal based on swelling in those areas. So we always advise patients on that. And over the course of the next month or two, couple months, it's going to really smooth down and may become quite red or dark in appearance at that point, because again, all that collagen has been laid down now, it's immature. And then over the course of the year, it's going to flatten, smooth out. There's different scar techniques and stuff to use or different products you can use, but it's going to flatten and it's going to fade. And we know that the scar is mature once that coloration is faded. So instead of being bright red and injected looking, it'll become the color of your normal skin.
Right. Yeah. So I'd make the additional comment there that depending on the pigmentation of your skin, so for kind of Caucasian white skin, it's generally red, darkened. But yeah, it really, depending on your skin tone, it's really like a hyperpigmentation. There's more pigment than there will be ultimately over the course of that healing period. And also it's very typical for the scar to be thicker, and we call it indurated or hardened in the early stages. And over the course of months, that hardness disappears and returns to the soft contour of the surrounding skin. So it becomes much less noticeable over that time. But, the initial appearance, and maybe even the initial appearance over the first couple of months, is not at all what it's going to wind up being at the end. I think that's an important thing for people to know.
Absolutely. So why don't we get nerdy on this, and why don't we go a little deeper on the topic? And so I think this may be valuable for our listeners. We're not going to spend too much time on it, but again, we want all of our recommendations and what we're saying to be backed up by the science. And so we at least want patients that are listening to us to kind of get a little bit of an idea of some of the primary sources of some of this information. So I think one of the big questions we get, or the people are, when they're really asking about scarring, is they want to know if their scarring is going to be normal or abnormal. That would you say? So I think that's kind of behind the question, even though we don't really get into it.
Yeah, and you're right. I mean, there are certain patient populations and individuals, they have had scars in the past. They've had previous surgeries. And for the individual, that's probably the best indicator of how they may heal this time around. Now, we are plastic surgeons and we do certain things to try to make scars as good as possible. But a lot of it is genetic in nature. And that fibroblast response that you're talking about, the amount of collagen that is placed, is often genetically determined. And certain parts of the body actually may have a more robust collagen response than others, depending on the thickness of the skin as well.
Absolutely. And I think that's, you're bang on there. And so I think looking at a patient's previous scars is very helpful. But the region, I think you're right, is also very important. So we know that the breast tends to be an area of the body that tends to scar quite nicely. And I think that goes back to some of those original studies in terms of tension on the body. So we know that skin tension is associated with scarring, how robust scars are. And there's something called hypertrophic scars. Those are very thick scars. And those can be associated with things like tension, infection, different things that can cause scarring to be much thicker. And we know the breast is an area that tends to have very little tension. So that's a good thing for the breast in general. But I was going to ask you just to mention quickly, I know we do have a study here that just looks at the relationship of age to thicker scarring. And I think as we kind of hinted at, the fibroblast may be a little bit more robust at earlier ages. Is there any things you look at? I guess we could also talk about how, we look at how you respond to earrings, for example. There's different things like keloid scars, which are a different topic. Those are something that are very much genetically linked. Do you want to maybe tell me just a quick primer on the difference between a hypertrophic scar and a keloid scar? Because they're named interchangeably. Patients come and ask, primary doctors ask, but there's a major difference. There are major differences. Do you want to just tell me what those are?
So that's an important point. People do come in and interchange those terms all the time. So a hypertrophic scar is a scar that is thicker than normal, I guess. And but the real defining point that differentiates it from a keloid scar is that a hypertrophic scar stays within the incision placement or wherever the laceration occurred. It does not extend beyond it. With a keloid scar, it's almost like there's almost a pathergy to it, meaning there's almost like it spreads beyond the area of the initial incision or the initial laceration. So keloid scarring can grow well beyond that, the area of the initial insult to the dermis. And that really is, I guess touching on like what causes a scar. Well, there are layers to the skin. There's the epidermis, which is your layer of the skin that sloughs off, that changes, that can be affected by things like chemical peels or just by physically cleaning the skin. That layer can sometimes come off. The dermis beneath that is the structural layer of the skin. And that's the layer that's really impacted by scarring, because the dermis you're born with is the dermis you live with for your entire lifespan. It does not change. And when you cut through the dermis, it's repaired, and it's repaired with collagen by these fibroblasts. And those fibroblasts will then kind of remodel that collagen over time. But no new dermis can be created, and there will always be something left if that dermis is cut through.
Yeah, that's great. And I think that's another reason why we go just to our deeper dive here in terms of hypertrophic scarring. So that's thicker scars that are within the confines of the incision, which is the most common thing that can happen to a patient. I think the number here in the Plastic and Reconstructive Surgery Journal shows, actually, I think this is from the Annals of Plastic Surgery, outcomes of 2,100 breast reduction procedures in the Annals of Plastic Surgery in 2015. Is basically we're seeing around 6%, but even up to as high as 20% of patients can have some element of poor scarring or hypertrophic scarring. And one of the risk factors is that in the younger cohort, so the younger group, which we're talking about today, that can be up to as high as 20%. And we do know that there's changes in the dermis, the skin thickness, as we age. So as we age, that incidence may go down. Now, I don't think we see that in our patient population, Matthew, but I think that is the data that we have.
I think it is pretty insightful data in that, yes, when you're younger, your dermis is thicker. You have a more robust response to healing. And also, I think in the younger patient population, maybe it also points to something different, that maybe they're a bit more sensitive to scarring and to how that scar appears. So it is, I think it's important for us to kind of take note that, 1 in 5 will at least have some kind of major concerns in their healing process about how their scars are healing. And maybe in this younger patient cohort, we need to spend a little more time talking about the scars and talking about that healing process and what they can do about their scars as they heal.
Absolutely. Yeah. We could put in the show notes. There's a great paper from the Plastic and Reconstructive Surgery Journal in 2019. And that was, it's called Complications in Quality of Life Following Reduction Mammoplasty in Adolescents and Young Women. So again, for our residents or medical students that might be looking for more information, or even other surgeons, that's a good paper. I think it highlights a couple of things that might be risk factors. So if you're a smaller breasted patient, you actually have a slightly higher rate of potentially thicker scars. Younger age, we already mentioned that. A couple other things that wouldn't apply to the young patient population is that when you're looking at large numbers of breast reductions, patients with risk factors for healing, those are directly related with poor scarring. And we know those are a couple. One is smoking. So that's kind of a non-starter for you and I, Matthew. I know in other areas of the world, they're not, like I know some of our European colleagues, older patients smoke, so it's a difficult one, but it's kind of a non-starter for us in Canada because we know it's such a major wound complication factor.
Right. I think not only do they not have as good of a healing response because of the blood supply to the area, but that leads to that increased risk of infection, which then can cause these incisions to actually fully come apart and dehiss. And that similar to that, all those things are factors that can lead to significantly less ideal scar, which may require revision at some point.
That's from the Aesthetic Surgery Journal. Is a great one. Has a nice systematic review. And then the other one was BMI.
Yes, exactly. Yeah, absolutely. So body mass index, which just as a quick review, is just basically a ratio of your height to your weight, right? So with a body mass index of 30 or above, and you can calculate for yourself, there's many online calculators of what that is. 30 or above is considered obese. And, there's a lot of questions out there about, who is safe to operate on, especially for kind of elective surgery. And then in Ontario, where we live, elective surgery that can sometimes be government funded. So body mass index for a lot of surgeries is directly related with complication rate. And a couple of those, one would be, for example, increased seroma risk in the breast reduction population, also increased incidence of dehiscence or of these incisions coming apart.
Those are big words, though, right? You got to explain what seroma means and what dehiscence means. Yeah.
Yeah. Okay. Go ahead. Well, seroma, sure. So seroma is basically a collection of fluid that occurs in the breast that the body cannot deal with. So very often after surgery, there's swelling, and that's because there is fluid in the breast. Obviously, with removing all kinds of tissue, there will be fluid that the body replaces it with. A seroma, though, is when that fluid collection actually becomes problematic and it doesn't go away. And sometimes it can become chronic, it can be encapsulated, and it can become infected. So that is one of the bigger issues seen in the patient that are overweight.
I think we've kind of done a shallow but deep dive in a lot of ways with this question. I think we can maybe leave it though with a more optimistic tone, because although these are things that can happen, despite this, I think there's great data and studies that say that basically 95% of patients report decision to undergo breast reduction was correct, with impressive scar fading observed on long-term follow-up. And that's from the Annals of Plastic Surgery Breast Reduction Outcome Study done in 2000. And then quality of life improvements persist regardless of whether scarring complications occur. And that was from Plastic and Reconstructive Surgery Journal in 2019, that same paper that we mentioned. So I think despite the potential for scarring and scarring complications, again, we don't anecdotally in our practice see a lot of issues, although there are the occasional patient that does have a problem. But despite that, the decision to proceed with this surgery is the correct one for the majority of patients.
I think that's exactly right. I think, the location of the scars, where those scars are placed, I think have been thoughtfully made, and thoughtfully made in that they're well hidden in any kind of clothing, a bikini, even a bra. It's very hard to see. Also, they tend to heal nicely. They tend to heal with kind of around what the pigmentation of the surrounding skin is. It tends to heal and soften. So the ultimate product after the healing process, however long that may take, is excellent. We just talked a little bit about how it can take up to a year for that scar to mature. What are some things that you recommend to your patients to make sure that their scar outcome is as good as it can possibly be?
Absolutely. So I think we know that kind of manual massage is very helpful. So the physical act of breaking down, helping the body kind of break down that collagen, that disorganized collagen, can really help in terms of helping the body to restructure and rearrange that collagen.
Yeah. When do you start that? When do you ask them to start that massage process?
So that process in my practice is usually around, probably around the 4 to 6 week phase in terms of timeline. How about you? I'm curious about when you tell patients to start doing that.
Yeah, it's similar. It's usually about the 3 to 4 week mark, because at that point, enough collagen has been placed in the incision line that things aren't really opening up so much. But I think you're right. It can be up to 6 weeks if there are like little openings. Sometimes there's a little bit of fluid coming out, or little openings in the skin. So yeah, you kind of wait. Once the skin is closed up, I think it's safe to be placing manual pressure on these scars. Yeah. You wouldn't want to be introducing things like bacteria and things like that if things are still open, though.
Correct. And so I think that's the manual aspect that anybody can do. And then I guess the next most common question I have in the post-operative period is, what do I put on these scars? So maybe you could, and again, my main thought is that the act of putting something there and draws attention theory will ensure that there is massage happening. So I'm generally positive about most things, as long as they're not going to be associated with lots of skin reactions. So I have noticed, a lot of patients with maybe some more traditional medicine backgrounds or interest in like homeopathy. There's a whole range of things that are being put on scars. Some of those things do cause irritation that I have to mention that to them. But if they're not having irritation, I'm okay with most of them. And some of them do really cause more redness and kind of robust scarring. But in terms of evidence that we have just in the kind of allopathic medicine domain, what are those things in your practice?
That's exactly right. So there is some limited evidence to show that products containing silicone may improve overall scar quality. And maybe it's just the pace at which it gets to its final quality, but it seems to have a positive overall impact. So there are creams or silicone creams that can be applied, as well as tapes. A tape, or kind of like, it's almost like a like a band, I guess, of silicone that can be placed on these incisions. I guess a couple things about them. One is that they tend to be a little bit more on the pricey end. It is the creams and the tapes tend to be there's a cost to them for sure, and they tend to need to be placed on the incision line for prolonged periods of time. So for the tapes, I think the recommendation is up to 23 hours a day. But and
I think it's for 3 months, right? I think this is based on the burn literature. So there's good evidence for silicone effect in scars because it's been used in burn surgery. There's really just not a lot of great data on most products, unfortunately, yet that I'm aware of, and I don't think much has come out since the last time I did a real deep dive into it.
But I guess to touch on what you were mentioning about people putting all kinds of random stuff on scars, I think the one thing about scars is they do not have the same ability to produce moisturizing ointments. Basically are important because your scars themselves tend to, especially in winter months, they tend to flake, they tend to become quite dry. So any moisturizer that works with your skin is generally a good idea, because it's not going to have some random new chemical in it that your skin will react to. One of the very common ones that I see reactions to is something like polysporin, for example. It has just so many different chemicals in it. And when you use it for a short term, things like just a topical kind of small little infection, it's great for a few days. But if you get beyond a week to 2 weeks using polysporin every day, the skin will develop this red appearance that is hard to differentiate from an infection, when in fact it probably is just a local reaction to one of the chemicals in that large cocktail.
Absolutely. Yeah. So I think we've covered quite a bit in terms of scars, taking a little bit more of a deeper dive. But yeah, anything else you want to cover?
I guess the one last thing about scars is maybe not so important on the breast because they're often covered by things like bathing suits or clothing. But scars in general in that first year, because they're undergoing this remodeling process, UV light really needs to be avoided. So some kind of sunscreen or just physical coverage of the scar in that first year is important, because that UV light can cause hyperpigmentation. And really the whole process of remodeling and improvement of a scar is dependent on that scar becoming less pigmented over time. So I do advise all patients for scars anywhere on the body, even in breast reduction on the breast itself, if people are getting exposed to UV light, to really avoid that in that first year after surgery, if possible.
Yeah, and I actually have gone so far now as to advise sunscreen placement on the scars on the breast prior to placement of a bathing suit, because I do find my patients after breast reduction are feeling more confident, would like to go out, spend more time outside wearing bathing suits, but most bathing suits aren't actually UV. They do have some UV protection for sure, but there's often UV light that can penetrate through that clothing. So before putting on that bathing suit, make sure to put on your sunscreen on those scars until those scars have faded. And that will typically take about a year or so, maybe a little bit longer. But until that's done, any UV light that hits that scar can create that increased redness or hyperpigmentation that Matthew mentioned. And wait until it's mature, and then it can be treated like normal skin.
Exactly right. So I think really for everyone then, some kind of moisturizer, whatever they prefer. Some people, there can be certain oils or whatever that people normally use. If you use it normally, it does not cause a problem. It shouldn't cause a problem after surgery.
Yeah, I think, we'll definitely be talking in terms of skincare products within our kind of facelift population that we can discuss in the future a little bit more in terms of skincare regimens. But I think overall those are the very good principles for people can use that can be really helpful for them in their scar maturation process.
Yeah, so I think this podcast, at least this episode today, is well directed, I guess, at this kind of earlier age group. I think we haven't really gotten into a couple of the other topics that this age group are interested in. And I think we could maybe do that in our next couple of episodes. We'll kind of divide this topic up a little bit further because there really is so much to talk about.
Yeah, let's do in terms of a teaser run. We got into a little bit more about sensation after breast reduction. That also applies to breast lift surgeries. And then we could, just in the younger population, a really common question or concern is breastfeeding. This has become much more top of mind as breastfeeding has become much more appreciated. Sometimes a little bit more pressure is placed on women.
That's true.
In this process, you having 4 children and me having 3, we've definitely seen that, I think, in our own experiences. but we can go through that a little bit more.
Yeah, let's do that. Let's do that maybe in episode 3. Let's get on to those other topics that we're hoping to do in episode 2. But gosh, there's just too much to talk about.
There really is. And I think, we're really getting the chance to really be pretty nerdy about the topic, which is good. Again, we can't in a 30-minute consultation cover all these things, but I think, at least I hope our patients will and our colleagues will find it helpful in terms of the thought that's been kind of put into these things.
That's right. Yeah, I think every surgeon really does have to come up with reasons for why they do things. And certainly, I think most surgeons in this day and age, most plastic surgeons certainly are pretty attentive to emerging evidence. And it's really, it's a good time, I think, for medicine overall, because that evidence is more available as well.
In our outline, we were hoping to kind of cover within our podcast, like a kind of more topic that's kind of like happening now. I think we're going to be out of time though for this week, but we will try to incorporate that into our processes, go on a deep dive in something that's of interest, but then really talk about something that's happening now. Although the studies that we looked at today, some of them were quite recent. So I guess that's good. Okay. Thanks. Yeah. Nice chatting with you, Matt.
Thanks, Mark. That was a great day in plastic surgery consults.